Good afternoon. I'm Melissa Anderson. I'd like to thank everybody for joining us today to talk about the fentanyl crisis, treatment, recovery, and solutions. I know everybody's likely got a busy schedule as we're heading in towards the Labor Day weekend. So thank you for taking your lunch hour to interact with us. I'll be joined today by Dr. McClain, but the both of us would like to keep this very interactive. So if there is a question or something that you would like us to clarify, please feel free, raise your hand, put something in the chat, and we'd be happy to take those questions. And I think that's a more engaging discussion than just a didactic. But just to introduce ourselves, like I said, I'm Melissa Anderson. Physician pharmacist by training, a director of public policy and advocacy for BrightView Health. My undergraduate degree is in analytical chemistry. So jack of all trades, master of none. And you'll hear my Appalachian accent sneaking out today, regardless of how much it is. For about a year and a half. And I work with pretty much every department in terms of coordinating policy in different realms of federal and state advocacy, because in behavioral health and addiction treatment, state law, federal law, policies are always changing. So, and we have to adjust our treatment model based upon those changes. And how do we make sure that we can serve everyone who needs help? So it's never a dull moment in that realm. But I'll let Dr. McClain introduce herself now.
Appreciate that, Dr. Anderson. And I am Dr. Cheryl McClain. I've been with BrightView for a little over a year and a half. Currently the Kentucky Medical State Director here at BrightView, and very happy to be alongside Dr. Anderson and a part of this discussion today that I know that we're all kind of on board and worried about and need some more information. And certainly appreciate your time as well. I hope you're munching on something for lunch. And feel free to do that. Raise your hand if you have any questions. As Dr. Anderson mentioned, we're going to keep this formal. We're going to try to get through all the information. We've got a significant amount of information. We're going to share some stories as we go through. We've got some questions at the end that we've already kind of put out there, just in case we don't have enough from you guys, but we want them from you guys as well. And actually these were from you that we have put in there and have some answers for. So in appreciation for your time, let's shoot this forward.
Thank you, Dr. McClain. So first wanted to talk briefly, kind of an introduction to fentanyl. Fentanyl is a synthetic opioid. And when I say synthetic, that just strictly means it's a man-made opioid, as opposed to something like morphine, which is a derivative from the poppy plant. Fentanyl is strictly it's a man-made, and it's what we call an extremely high potency opioid. So it has an extreme strength in terms of binding to the opioid receptors, producing its effect. It is 50 times more strong or more potent than heroin, and 100 times more potent than morphine. And you'll hear a lot, with fentanyl in the news and in different media sources, everyone just kind of throws out the term fentanyl, but I don't hear a lot of people delineating whether we're talking about illicit or legal pharmaceutical fentanyl or illicit street fentanyl. And obviously there are some major differences there. When you're talking pharmaceutical grade, you're talking, highly regulated, that's coming from legitimate legal labs. It has been tested in terms of concentration and purity, versus something that you're going to be getting from a street lab or a street purchase. And then you're never sure as to what analog you have, what concentration you have. So wildly different. And I think it's always important when you're talking about fentanyl to kind of make that delineation, whether you're talking about licit or illicit. But speaking to illicit fentanyl, this is the culprit that is really driving that escalation in overdose deaths across the nation, and has been doing so for some time. And unfortunately, it has become the leading cause of death for adult Americans 18 to 45. And the highest group now that we're seeing in terms of overdose deaths secondary to fentanyl is our youth. And that's the most rapidly rising overdose death due to fentanyl in terms of youth and young adult, ages 14 to 23. And with the youth age group, fentanyl is causing more deaths than heroin, methamphetamine, cocaine, prescription medications combined. So this really is the culprit that we have to get a handle on. Next slide. Looking at the scope of the problem from a national and individual state perspective, we know that in the last preliminary data that I saw from the CDC, and that was ending in January, that more than 107,000 people have died secondary to overdose just in the United States alone. 75% of that was due to or had at least one opioid on board. And almost 67% of those deaths did involve a fentanyl analog. Looking at the state level, you'll see there below, and these are the 7 states that BrightView operates in. Moving from a 70% fentanyl involvement in overdose deaths in North Carolina, it rises up to 94% in Maryland. So this is really, again, just really the culprit driving this rapid escalation, and why we're talking about this today. And also, this is, as we're approaching, before we get to the Labor Day holiday, it is International Overdose Awareness Day on August 31st. I know here in Lexington, we will have an event. Lexington, Kentucky is where I am based. And I know many communities across the US will actually have, local events, and typically there's speakers, there may be some harm reduction measures, but it's about honoring those we've lost to the overdose crisis. Next slide.
Now we're ready. Yeah, appreciate that. So Addiction 101, what exactly is addiction? Well, I want you to kind of step back a little bit and think about high blood pressure, think about asthma, think about those chronic conditions that we all know about. And I want you to now consider addiction in one of those. It is a chronic disease involving complex interactions among the brain, rewiring of the brain. It involves genetics, environmental changes and exposures, your life or the individual's life experiences. And it can happen to anyone across the socioeconomic divisions, across the races, across, it can touch anyone, and has touched many families, and you all probably know of someone that it has touched. Risk factors lined up there: genetics about 50%, environmental factors about 50%. So one or the other. Epigenetics has some play in that as well. Prior trauma, early age. I've had patients tell me their parents sent them out at age 5 with some marijuana and their toys to go play by themselves. They didn't ask for that. That was given to them. And their parents probably had their parents do that. So no blame here. We're just looking for solutions. There's also some drug and drug metabolism. There's cultural influence. That's just what we do. That's just what we do in this family. That's kind of, the way it rolls. Yeah, we could say choice leads to that first use. But as we're going to talk about through this, you're going to see that it's not all choice. It absolutely isn't. Once that first prevention and treatment approaches for addiction are generally successful. We don't think about that, do we? Sometimes we don't think about an addict being able to recover. Sometimes we kind of stereotype them. So let's open that up and think about that. It's just like any other chronic disease. You think about diabetes, and you think about those folks who, constantly their sugar's going up, they're better, it goes down. Well, this is the same way. Next slide. How does it affect the brain? Quite oftentimes we hear about addiction hijacks the brain. And sure, you can look at it that way for sure. But let's talk about that. Let's talk about the neurotransmitters. Let's talk about the wiring, and what we hope to have happen at some point is rewiring of that brain. So if you look on the left of the side, you're going to see that some of the areas of the brain, these are all working together, obviously. And what happens with pleasurable activities and some of the things that we do is that release of dopamine from these areas, and then they affect that nucleus accumbens. And so when that dopamine is released, it's a reward. It causes pleasure. The difference is we all get that release. Eating, for example, some other activities. I enjoy riding horses. You probably have a hobby that does that. The difference is the amount of dopamine that is released. So if you look in the middle of that slide, it shows you repeat use of substances that markedly release that dopamine, such as heroin, such as fentanyl. In our discussions, results in a decreased response to opioids. So what does that mean? That means we have to use more to get that same response. And part of that is because we're also looking at those dopamine receptors, those binding places in that brain area that take that dopamine and hold on to it. So we're getting decreased receptors downgrading with a decreased response. And so we have to have more to have that same response. Decreased dopamine that we see sometimes in depression as well, right? That kind of goes on with this, causes difficulty with attention, short-term memory, decision-making, feelings of loneliness and low self-esteem. And a huge part of recovery is getting that back, is getting that self-worth back. And that's a big part of it. I put this little graphic in here below. It's actually a video. It's about 5 minutes. I encourage you to go watch it. It's a bird, and he starts out just on a little stroll. He walks by this pile of yellow stuff, and the first time he goes by it, second time goes by it, and he's like, oh, I'm going to try that. And then, boy, does that start that pattern. You can see several different times throughout this video. And then all of a sudden he starts crashing, and then all of a sudden he needs more and more. It's really humbling, but it brings it home. It's a nice little cartoon. When you get the PDF, you'll have that link there, but you can just Google nuggets and in YouTube, and you'll find it. Next slide.
So looking at fentanyl, and specifically again, we're speaking to illicit fentanyl. How is there so much? How is fentanyl reaching so many Americans, so many people across the globe, and causing such widespread destruction? Initially, we were seeing the majority of fentanyl and what we call fentanyl precursors, those chemicals that are combined to create fentanyl. The majority was coming from labs, predominantly in China, and then being actually sent to China to like a third party intermediary such as Mexico, and then coming across the US-Mexico border. And I know now we're seeing an increase in labs throughout Mexico and throughout Latin America, because that is often an easier route for direct cross into the US. And where fentanyl is so potent, it takes such a small amount that you can, so it's a drug of choice for smugglers, because they can take a small amount of fentanyl and then make a very large batch. And what I said there, that the fentanyl is cut in batch. So they'll take the base of their fentanyl, and they'll take that base, and then they'll use different cutting agents. And a lot of times a DEA agent that I know, he told me that a common thing they'll see is the NutriBullet. So they'll go into these homes, and basically, this is not what we see when you see a fentanyl pharmaceutical. In the street lab or in the street world, they're taking their base fentanyl, throwing in the NutriBullet with the cutting agent, and then making their big batch for distribution. And unfortunately, we don't know what fentanyl they're starting with. Fentanyl has a number of different analogs, or what I would call siblings, and all of those have different potency, different ability to cause effect, different risk of death. So we don't know what we're starting with, don't know what concentration we're starting with, and then we're adding, different cutting and agents and throwing all that into the NutriBullet. So we have no idea what that smoothie is going to look like. And, it could be when you batch it out that, these 10 tablets, these 10 pressed tablets have all the fentanyl and the rest have all the cutting agent, or it could be dispersed. So this creates a higher and higher risk of those, what we call the deadly batches. Again, just because don't know what we're starting with, and we don't know what we get as the end result, compared to a pharmaceutical product where you know exactly what you're starting with, and it is tested for concentration prior to distribution to a hospital or a pharmacy. Here we have no idea. And unfortunately, not only is the fentanyl being batched out and sold for those seeking opioids, it is also now being added to cocaine, to methamphetamine. I heard of one instance, and I believe it was out of Massachusetts. It was present in counterfeitation. So people will take this fentanyl powder, they'll utilize what's known as a pill press. They'll press that into a tablet. And my history as a pharmacist, I've counted thousands of opioid tablets. And even to a trained eye, some of these counterfeit medications, these counterfeit tablets or pills, they look identical. So you have people on the street that may be seeking an oxycodone or a Percocet, or even an Adderall for performance enhancement prior to a big exam. And what they actually encounter is fentanyl. And it's even more risky for those that have zero opioid tolerance. Next slide. So speaking to potency, and again, not knowing what we're starting with and the different risks associated, what are the differences between heroin, fentanyl, and then carfentanil, which is increasing more in the news and different media stories. Looking specifically first there on the far left at heroin, and I did list diamorphine because in Europe, in the UK, this is actually available as a pharmaceutical. So it is of the three here, it's the only one that is not synthetic, meaning so it's partially derived from that poppy plant and then partially created in the lab. In the United States, it's a Schedule 1. So that means it has no legal pharmaceutical or medicinal use. And there's the formulations that are available for pharmaceutical medicinal use in Europe, in the UK. It's available as an injectable solution for pain. And then it's also utilized as a tablet in the treatment of opioid use disorder. And in terms of what you'll see from illicit in the US, obviously it's not going to be in our pharmacy or hospitals. It's going to be a street product, and it's typically in either powder or more of a tarry substance. And its potency, usually with opioids, you're always referencing a morphine equivalent or comparing it to morphine. So that's what I did in terms of listing the different potencies.
Dr. Anderson, I think we lost out on some of that, but hopefully everyone got to look at those slides, and we can certainly answer that if need be. We froze up a little bit there. So here, what's the real risk of fake medication? So what? It's a pill. I can pop it, I can take it, I can do whatever I want. But what happens? What happens is you don't know what you're getting. Just as Dr. Anderson had just mentioned, we're getting these pill press machines where they can look exactly like what your prescription looks like. So when you look at these over to the right here, you see on the top the authentic oxycodone to the left, and then the pressed pill on that bottom. To the far right is the Xanax bars. See that a lot. In the middle there is Adderall. So, you know, college kids, for example, we're seeing that more and more in some of these college towns. They think they're getting Adderall to stay up at night and study. And in fact, it's pressed fentanyl, and there has been some deaths to that. I've actually had a patient come into me, and over the weekend, she had her friend in her arms died from a pressed oxycodone pill. Actually, I think that was a Percocet, same idea, but so it's out there. It's rampant. The Xanax, and patients will tell you also, they'll tell you, you know, I know that it didn't taste right. It wasn't right, because I'll share with them, your urine toxicology shows me fentanyl. And they're like, I didn't take fentanyl. And I'm like, well, all I can do is show you and tell you what it shows. And they're like, well, I took a Percocet, or I took a Xanax, and I'll say, well, it was in there. You know, you just don't know what you're getting. We're seeing it laced in marijuana, for example. We're seeing it in meth. So it is out there. The drug traffickers are trying to make the biggest bang for their time, the most money, and it's resulting in these pills being on the street, and quite a bit of deaths associated with it. On the left is some information. Dr. Anderson, I don't know if you would like to add anything to that.
No, thank you for picking up there. I apologize. My electricity, my whole home just went out. The joys of of Kentucky living. No, that was pretty comprehensive. I think just really getting that message out there that if you buy something outside of a pharmacy, if you're not getting it from your pharmacy, we really don't know what we're getting. And I think sometimes there are groups of populations that aren't being educated. You know, I think this should be a part of every college orientation, every college freshman orientation, for starting nursing students, medical students, pharmacy students, making sure that everyone really understands and can speak to and educate about this. And then also, you know, there are folks that may be seeking, again, like I mentioned earlier, for performance enhancement. I know a lot of graduate students that have purchased straight Adderall. So they want to do better on their boards, or they want to do this, and they have no opioid tolerance. And no one has ever told them, hey, you could be buying fentanyl. So I always just like to know, let you know, anyone and everyone, because there is no group that's immune to this risk if you purchase outside of a pharmacy. And that's why I think it's so important to educate, and then also talk about, you know, fentanyl testing strips for utilization. If you buy medication outside of a pharmacy, it is really easy to stop and utilize a fentanyl testing strip and be able to know for certain that that's not what you're going to encounter when you take that particular medication. Next slide. So we wanted to go through, I think it's important, talking about, you know, facts and myths specific to fentanyl. And I know I've seen a lot of news stories in terms of, you know, even touching fentanyl. And this comes into play when we're, you know, providing support during an overdose, but even coming into contact with fentanyl can cause death. And that is a myth. Even touching fentanyl powder is not going to cause death. Administering rescue breathing or providing overdose support, if you come into contact, skin to skin contact, I'm not talking about powder to a mucous membrane, but just skin to fentanyl contact is not a risk. The way that, you know, there are fentanyl patches, pharmaceutical fentanyl patches, but they utilize some pretty high-tech technology to get that fentanyl across and into our bloodstream. So that incidental skin exposure, extremely unlikely to cause a problem. However, you know, just to be on the safe side, you know, anytime you're providing that support or those rescue breaths during overdose reversal, be aware, understand the risk. And I think if you utilize, you know, standard safety precautions, and once you have provided those breaths, provided that overdose support, you know, wash your hands, any exposed surfaces with soap and water. and use soap and water and not an alcohol based. So don't use, the hand sanitizers that are everywhere since the pandemic, because alcohol, if you have a fentanyl powder on your skin or a mucous membrane, alcohol will actually help that fentanyl, if it was transferred, to be disseminated through the skin or through the mucous membrane. So it actually does increase the risk, because soap and water is best. Next slide. So the next myth, somebody have a question? I'm sorry, I thought I heard someone. So the second myth I think it's important to talk about is, I hear a lot of people saying that fentanyl is Narcan resistant, or carfentanil, or all the fentanyl siblings that are available now, that they're Narcan quote resistant, and that is a myth. In reality, fentanyl or any fentanyl analog, they're opioids. So by nature, naloxone, when administered, is going to kick that opioid off the receptor. Now, you do have some fentanyl analogs, and particularly some of the ones that we're seeing in the street now in terms of acrofentanyl, furofentanyl. They will bind the opioid receptor tighter, and you may have to use, higher dose of naloxone or multiple repeated. I'm hearing that commonly, that you're having to need multiple doses. And if a patient comes through the emergency department, a lot of times they're just started on a naloxone infusion. And it does provide that additional support if you have a higher potency or a fentanyl or other opioid that tightly binds. But the reality is fentanyl overdoses can be reversed. And if you suspect an overdose, administer that naloxone, administer that Narcan, and go ahead and call for backup, call 911, and get EMS support there. They often have multiple doses available. And, if you do not have multiple doses available, just, again, administer what you have and provide supportive care until emergency medical services arrive. Next slide. So after we've provided the naloxone, reversed that overdose, what's next? And this slide is speaking to what happens after an overdose in the community, as opposed to what we would do inside of a hospital. Anytime someone experiences an overdose, that is a moment of crisis. However, moments of crisis are often what presents or what prompts the opportunity for change. So what that is, there's the positive light there is if an overdose is reversed and a patient survives, if a patient is alive, they have the opportunity to recover.
Dr. Anderson, I'll go through this.
Sure.
I appreciate that introduction there. Yeah, for sure. Whenever we have an overdose, it's a time that we can focus in, offer our services, and show that patient a different path. However, if you're around there when a patient has that overdose and is given that naloxone, be prepared for not some nice words. Be prepared for some anger, agitation, even severe sickness. So what happens is, as Dr. Anderson mentioned, when you give that naloxone, we talk about it kicking off that fentanyl. Well, all of a sudden that blocker, the naloxone's the blocker. So those euphoria, those effects, those intensity are gone all of a sudden. And it throws these people into what we call PIWD, precipitated induced withdrawal syndrome. So what happens is they go right into it. It's the worst. It's not the same as that fentanyl or the heroin or the opiates slowly coming off. It's acute. So what do? We give them encouragement. We stay with them. We talk to them. We give them a repeat dose, as Dr. Anderson mentioned, if we need to. I've seen associated with patients who needed up to 6 or more. At one point, I had a patient who's a nurse who was doing IV fentanyl during the day. She was sent away because of investigation. She went immediately, bought some heroin. It was fentanyl. Went to, thank goodness, a nurse's a colleague, did it there immediately. Cardiac arrest. She required 6 doses, and almost at that last dose, the ER physician was going to call it, but thank goodness they didn't. She proceeded in recovery and is doing great. So what else can we do? We can do a warm handoff. What does that mean? Well, that means you're not just giving them a piece of paper. You're not just sending them out with a number. You're actually maybe even taking them to that person. You're taking them to the counselor. You're calling and getting an appointment for them. You're giving them some hope and helping them find that path. Some of the things that we talk about: emergency department-based screening and referral, the expert screening tool, screening, brief intervention, and referral to treatment. I'm going to go through these quite quickly. Emergency department-based naloxone provision, take-home Narcan, biggest thing that can help prevent the overdose. Post-overdose outreach and follow-up. This is a team approach. Some call it the knock and talk. It's generally maybe a counselor and a police or a fire person. They go to the person's home and say, hey, what can we do? Let's get you there. Let's help you. There's a great little link there to some of this information that I encourage you to go look at. If available, provide, and this is in addition to that warm handoff, but go ahead and give them an updated available resource page where they can access some of those things, locally. Peer recovery, huge. No one can talk to a person using drug or is having some difficulty in here than someone who has experienced it. Peer recovery, that is an awesome resource. Finally, you want to maybe assess that person's need for transportation. Is there something that we could do to be helpful to get them where they need to go? Because a lot of times these folks are financially strapped. They've lost their car, they've lost everything, and they need help getting on that path. So we can go to that next slide.
And Cheryl, it looks like we had some questions in the chat.
Oh,
I
sure.
saw there was a question. The first question was, how soon after someone overdoses do we have to administer naloxone? I can answer that, or I'll let you.
Immediately. I mean, ideally, as soon as you see that happen, obviously, but the brain can sustain a certain amount of lack of oxygen. So it depends on the support, those ABCs, airway, breathing, and circulation. So, so that's what some of the things that we want to do is we want to support that, and until that naloxone can be delivered.
Like Dr. McClain said, literally as soon as possible. And that's why I do so much advocacy really around getting naloxone everywhere, because it's the sooner you administer it, the sooner you restore oxygen to the brain, the better. So literally, if you've got it on board, don't hesitate. Naloxone is one of the safest medications. If you give it to someone and it's not an opioid overdose, it will not harm them. And that kind of feeds into the second question I saw, Cheryl, was how many doses of naloxone could be administered by someone in the community?
As many as it takes. I've heard up to 10. So, now think back, some of the, this Narcan, naloxone has been around in somebody's purse or in somebody's car, and maybe isn't as strong as it was initially. I would still use those if that's all you have, but as many as it takes.
I think there may be, let's see. Okay, there's one more question before we move to the next slide, is why do they put fentanyl into other street drugs?
So cost, they want the biggest bang for the buck. They also want to, so if you're a drug dealer and you've got some good stuff, and those people that are buying it from you get that word out, hey, go see so-and-so, that stuff is really, it's really intense. It's all the bottom line.
capitalism. Next.
So here's some stories. And I hear these a lot. I was revived with Narcan, and that what happens afterwards. So I had mentioned, people are not happy sometimes. There are some though that are very appreciative. So in the upper left-hand corner, I had been in a coma. Most people aren't as lucky and blessed as I have been. I know a lot of people who've fallen out, and that's one of the terms, and are no longer here. I cannot tell you the number of patients I see whom they have no more high school friends. They're the last one of their family. That's another one. Their brother, sister's father. The other thing that's just, is when a mom comes in and her children, it's her children that she's lost. So for someone to be revived and have another chance, that's all we need is let's give them that chance. The lower left, above anything, you are amazing for what you did. Do not ever let someone shame you for saving their life. And that happens. Some of these, when they're revived, they get upset and mad. And how could you do that? How could you take away that buzz or that high or that feeling? Why did you do it? This person goes on to say, you are so amazing for what you did. So we just do what's right. To the right, after waking up from an overdose, I'm agitated and usually arguing. This person is being accountable and being defensive about using and was trying anyway to get away from them as soon as possible so they could go do it again. And that's what happens. You hear that a lot from first responders. These folks don't want to go to the emergency room. They don't want to go get help. They want to go use again. But why do they want to go using it? Because they're miserable. Remember, we talked about that PIWD and how miserable that is, acute withdrawals, miserable. So they want to go back and they'll do anything. Just like Nugget, they'll do anything to get through that. So next slide. What does it look like when we do have some successful recovery? What's it look like? The immediate response? Well, we're going to see that fentanyl in the urine for a few days, even maybe longer than 72 hours. It lasts a lot. It's lipophilic, so it lives in the adipose or the fat tissue, so it can stay up there, especially if you're doing some hair tests, it can stay even longer. We know anyone can fully recover from a fentanyl addiction, any addiction, and go on to live a healthy, a productive, gainful, high quality life. Everyone's recovery looks different. So what's right for one isn't right for the next. You've got to find, with maybe some motivational interviewing, what drives that person? How can you get them to see the light? How can you do that? So what are some of the things that is a positive outcome that you can kind of focus on? Hey, mending relationships with family and friends, huge. A lot of times the people using drugs, they've exhausted every single link out there, with family and friends. Picking up old healthy hobbies and habits that used to make you happy, maybe jogging again or knitting or whatever. Regaining custody of children, huge motivation. Love that. That's one of my favorite things to be involved in when people using drugs get their kids back because they've been on that path of recovery and have been successful. Gainful employment, expunging criminal records, probation, legal issues resolved, exercising, we kind of touched on that, paying off debts, being gainfully employed, now being able to get a car, opening a savings, having a checking account, basically just living like the rest of us normally do. Next slide.
So looking at, one ways that we help people stay alive to be able to recover is through harm reduction. In BrightView, we deploy what we consider a harm reduction focus or a harm reduction centered model. And really for us as treatment providers, that means we're non-punitive. We're going to meet you where you are and support you, whatever that path or however many times that takes. Unfortunately, I still see a lot of centers in a lot of areas where unless someone remains completely abstinent and they're coming back in, always with negative urine toxicology, they're kicked out from the program. And I'm like, I don't know any other health condition that we require perfection. It's so why have we singled this out? And we're immediately you've got to be perfect right off the bat, or we're not going to help you. And usually early on, someone is the most vulnerable. They need the most support. They need the most grace. They need the most compassion. And that's kind of what that's our focus at BrightView is harm reduction. And harm reduction in general means, reducing harm associated with any risk. Wearing seatbelts while driving, that's harm reduction. It's reducing the risk associated with a car crash. When we're talking about substance use disorder, what are the known risks of substance use? Be that opioids, injection opioids, particular, you're looking at, wound infection, skin infection, overdose, transmission of hepatitis or HIV. So those are some of the known risks. So knowing those risks, how do we prevent them? And fortunately now there are more, quote, harm reduction community centers or harm reduction programs than ever. And it varies wildly state to state, depending upon statute, policy, and unfortunately in certain states, state of Ohio, fentanyl testing strips. There's a piece of legislation right now that's being considered because those are still considered illegal. So, even though they provide, they're not a drug. And I've never seen anyone see a fentanyl testing strip and be like, today is the day. I see a testing strip, I must use, we see fast food restaurants every day and we don't pull over immediately for those cheeseburgers. So I don't know why we believe that providing people with safe equipment, safe education, re-engaging them is going to encourage drug use. There's not been any study that I have seen that says that, that has actually collected the data showing that harm reduction encourages or enables use. What it does is reconnect. For many, it's the first bit of compassion, the first time someone's looked them in the eye in years. And you're meeting them where they are and providing the patient with what they're looking for that day. For some, it may be a referral to treatment. For others, it may just be clean supplies or naloxone, or just take some resources or supplies for their friends. You are offering a wide array of services and letting the patient engage and choose and have some empowerment. And I did put there the second bullet point is abstinence should not be a requirement for participation. Unfortunately, there still are some programs in parts of the US that do require abstinence to be part of their participation, and they have that as the only goal. My personal thought is, it's the only goal should be enabling breathing and enabling connection and distributing compassion and letting people know they matter and letting people bringing hope. And maybe for some that, again, believe that medical professionals and community professionals actually care about them. I think that's kind of the first step to recovery. And that's part of harm reduction. And it can be as simple as connecting to community resources up to what's known as safe consumption sites. I know that those are under operating in New York, and California did just pass legislation. I'm not sure if Governor Newsom has signed that yet, but California looks to be the second state to offer safe consumption site operation. And to my knowledge, in the state of New York, in the months that they've been operating the safe consumption site, where folks can come, they're bringing their own product, they're consuming that in an area that is safe with clean supplies around medical professionals that can reverse an overdose. There's not been any overdose deaths in that safe consumption site in New York. There have been many overdoses, but no deaths. So what harm reduction does is it reduces the number of overdoses, reduces the deaths, decreases the risk of transmission of different viral diseases. And again, it reconnects, which I think sometimes that's the most important part. Reconnection and letting people know, hey, I care about you. And I'm going to support you regardless of what your path to recovery or your path to safer use looks like. Next slide. And tying that harm reduction into advocacy. Like I said, harm reduction and even addiction treatment, behavioral health looks so different state to state. In any other area of medicine, a heart attack where I'm at in Lexington, Kentucky, will be treated like a heart attack in New York, will be treated like a heart attack in California. It is a medical illness. If it has the same underlying cause, it's going to be treated the same. With opioid use disorder, no 2 days, no two centers in the same city may approach it the same, and much less deliver any measure of quality of care. And the way we change that, one way I believe is establishing policy and changing legislation to ensure and mandate that people are offered evidence-based care and ensuring they receive quality care. And we need as much, I want to put a help needed on this slide, as many advocates as possible, because I think there's power in numbers. We need people, I advocate for Shatterproof at the national level, for NAMI, for several different groups. So I'm a registered state and federal lobbyist, just trying to drive these changes so that addiction is treated like any other healthcare illness. And some of the things I think, some of the basic changes I would like to see, and I'd like to see in my lifetime. I'm one of those folks that Dr. McClain was speaking to. I've lost 1/3 of my high school graduating class, 5 family members, and there's 17 of my circle. It is every holiday, every couple of months, it is unfortunately another death. And I think until we see some of these basic changes, ensuring quality care, standard of care, making sure our healthcare professionals are educated. In pharmacy school or medical school, I did not receive any lectures on substance use disorder. My clinical rotations, I saw a lot of, here's how we negatively reinforce to the patients. When they come through the emergency department, we're going to slam naloxone. We're going to make them have the most negative experience. It's the reason patients will choose. They'll know they have a skin infection. They will wait until they're unconscious and somebody else takes them, because they will not. They're not going through the emergency room. There's nothing worth how they're going to be treated there. And a lot of my friends in recovery, they still won't go 10, 15, 20 years out. Their healthcare experience was so negative, they still won't engage. So we want to provide education and make sure our healthcare professionals are treating this patient population with compassion and respect. We want to increase the workforce, increase what nurse practitioners, physician assistants are able to do in terms of treating addiction, making sure that medications are available, making sure that naloxone is available. I feel like we have defibrillators everywhere. So should naloxone. Naloxone should be everywhere. It's one of the safest medications, doing a lot of work getting it into our schools. We're seeing middle schoolers. Middle schoolers are dying now, and there's no naloxone to be found. And I know the state of Kentucky, there was a bill in this most recent General Assembly, and unfortunately, it never even made it to committee. And it was just the bill was only asking to put naloxone, 1 to 2 doses of naloxone into our schools. Because if it's not there and a child overdoses, they're likely either going to pass away or have a brain injury from lack of oxygen by the time EMS is able to get there, by the time they get to the community hospital. Let's get naloxone into our schools, and let's decriminalize and expand harm reduction. And last but not least, I think first and foremost, let's all continue to do what we can to fight stigma. Next slide.
We can make a difference. One of the questions that I saw came up kind of asks is what do you feel, I'm going to a question here, what do you feel specifically something healthcare providers like our BrightView folks could do to help educate the patients and decrease the prevalence of this issue? Well, one of the big things I think is in that is this issue of we don't know what you're getting. You don't know what you're getting. These pressed pills, they look so good that people don't know. And so educating that, telling them about their urine toxicology. Did you know that this showed that? And actually showing it to them, because they're going, I don't know, I've never, well, here, let me show it to you. All I can do is show you what this shows. So basically education, reassuring, utmost, show respect, courtesy, non-judgmental when we talk to them, understand that they're going to go through the woes and, waxes and the wings. They're going to have a good week, they're going to have a bad week. They're going to have 2 good weeks, maybe 1 bad week. And we have to be there with them. We can't get our own bias in there. We can't get our own frustrations. We can't bring stuff from home and help them. So we need to just be there for them. Great question. So we asked patients at BrightView, what is some of the things that you've seen about your recovery? So what did your friends, family, and the community most misunderstand about recovery? Well, we're not bad people. We're just trying to get good. Just sick people who want to get well. They understand that they don't make this choice anymore. Their brain is not their friend. I tell them that all the time. Your brain is not your friend. You can make, you might be thinking it, that cognitive behavioral therapy, use those tools, do a different behavior, break that thought. Brain's not your friend. Let's go. What helps keep you in recovery? I was tired of being tired. I had reached rock bottom, homeless shelter, lost my wife. I hear this all the time, lost everything. I either had to change or die like the rest of my friends. And I hear that too. I just don't want to die. This person said, dying doesn't sound like much fun. How would your friends and family say you've changed most during your recovery? This is big. I'm more honest and dependable. They can finally now be accountable and take care of their children, have a gainful employment, get that financial security so that they can get their own home. And then finally, I actually want to live and have begun to love me. Huge. Next slide.
So this slide is, does addiction treatment work? And this is a quick summary. I know we only have 5 or 6 minutes until we reach the 1 o'clock hour. So try to walk through this quickly. This is from our BrightView patients out of Ohio. And we wrote a white paper summarizing the results. If anyone is interested, can provide the link to that white paper as well. And we were able to collect data on our patients and show what changes can occur when patients are able to get into treatment, stay into treatment, and looking at the measure. This is referring to measurement-based care. What are the measures that we say addiction treatment works? Because like with diabetes, you may look at hemoglobin A1C, different health conditions have measures that you would say treatment is working or it's not. Addiction treatment, we're still trying to iron out what is successful treatment. Some audiences, this is controversial in terms of abstinence. We were able to show in our patient population in the first 90 days, there was 70% decreased illicit use. That's substantial, with many patients reaching that complete abstinence. In that first 90 days, we had a 1/3 decrease in ER visits. We had, patients having decreased arrests, increased engagement with their families. Within 6 months, unemployment decreased by 50%. Patients are starting to increase their participation or re-engage with the primary care or other medical providers. So again, in 3 to 6 months, they're having decreased illicit use. They're visiting the ER less. They're re-engaging with other healthcare professionals. They're re-engaging with their family, their friends, becoming a member of the recovery community, getting employed. That's the foundation, is really being able to get employed, reconnect, put a roof over your head. Those are the basics, that foundation of recovery. And we were able to show that getting people into treatment and helping them stay there, they were able to accomplish that. So we really believe addiction treatment works. We just got to be able to make it more available to those that are seeking it. Next slide. So now we've got 3 minutes for questions, Cheryl.
All right. Let's go through those ones that we have there. And then if anyone has one, I'm watching it over here as well. So
we've got 3 minutes until 1, and so we understand that you guys may have to step off. We're going to walk through some more questions.
What you looking at, bro?
I'm sorry, what?
I think that might have been an accident.
Okay.
All right. So one of the questions was fentanyl in pregnancy. So if you look to the left, we do see an increased risk in poor fetal growth, stillbirth, preterm delivery, fetal distress during labor, although that may be more with heroin based, but regardless, we still could see that. And then of course the neonatal abstinence syndrome, that is not related to dose of MAT, lower dose, higher dose, doesn't matter. During pregnancy, we often have to go up to that higher dose. That doesn't mean mom is being negligent or wanting to use it. Just means there's a change of metabolism, and those urges and cravings are real, and we have to go up on the dose. It doesn't mean baby has more neonatal abstinence syndrome risk. So we have to encourage and educate our moms on that, so that we can keep them out of harm's way. We do know that MAT gives higher, better outcomes than not using MAT if you're going to use. So it does not increase the risk for infertility, miscarriage, or birth defects. And we don't really know if it's behavior or learning disabilities increase with its use. Next slide. So, Dr. Anderson, chime in here at any time.
Sure. Looking, in terms of routine drug testing, and when you say routine, a lot of times we're referencing the potty and dipstick. Obviously, the cheaper the test, the more narrow the things that you're testing for, and the greater the concentration will be required to test positive. At a treatment center, we do what is known as liquid chromatography mass spectrometry. Literally, that's a chemical process where whatever is in the urine, you can identify in a lab. That is extremely costly and requires a specific lab. So, there was a question directly, why is fentanyl not part of hospital testing routine? That requires, if a patient's only going to be there a small amount of time, that would require, if the hospital isn't a large academic institution, it would have to be a send out. So your utility there, if someone's coming in for an overdose to the emergency department, we're going to treat that like an opioid overdose. It's going to be that supportive care, and we're going to treat that pretty much the same. And then if, obviously on the back end, that could be a send out. There's not really a utility or a need to know specifically what opioid that is, what concentration. Now, if you've got a professional, maybe in a physician's health program, or a nurse going through the recovery process, they're often going to have that hair testing, have that gas chromatography mass spec that's going to capture whatever substances are there. But in terms of what is the basic, and they're listed there, and those are the 5 that are pretty much required when someone is in a substance use disorder treatment program. And that is what we test for at BrightView as part of our basic test. And then we are depending on what state we're in, every state has different mandates, different cutoffs in terms of concentration that you have to test down to. It really, again, this is an area for the legislative policy change is much needed. Drug testing can be an hour or 6 all on its own. Next slide. And I know we've probably hit that hour, but we're going to continue. Feel free if you have to hop off. We're going to make the materials available to everyone, but we're going to go ahead and finish out these questions. So if you have the time, hang around with us. Otherwise, we'll get the materials out to you. Go ahead, Dr. McClain.
Thanks. So recognizing opioid overdose, what's it look like if you come up on someone new? We've kind of talked about what to do. To the left, it's going to say one of the major characteristics of this is it's fast. It's fast. So these folks, they're gone. They're limp. They're out almost seconds, milliseconds, maybe minutes, but generally fast. If you come up on someone you didn't see it, what might you see? They're going to be generally on their side. They might be slumped over. They might, you might still see the needle in their arm, the needle laying next to them. Their face could be pale, clammy to touch. They're going to be limp, fingernails, lips blue or purple, not getting that oxygen. They might be vomiting or gurgling sounds. If they are vomiting, turn them on their side, left side typically, and help that prevent them choking on their own vomit. They can't be awakened or they cannot speak. Breathing slows or is stopped, and the heart slows or stops, and there's no pulse. Next slide. Preventing overdose. Number one, get that Narcan out there, naloxone. There are other brands. Narcan is a brand name. There are other brands. There's actually one now that has a higher dose in it than the first one that came out with the brand name Narcan. So nearly 40% of overdose deaths occur while someone is present. So there's an opportunity. If you don't have that Narcan, do as much of the first responder ABC support life, basic life support as you know and are comfortable with. Be respectful and non-judgmental. Educate. So local resources talk about harm reduction, like we talked about a little bit today, in form of MAT options, treatment centers that take walk-ins, for example, reputable sober living housing, and maybe the 12-step programs. For persistent users, and this is hard for some of us to do because we don't want them to use, and so you feel like you might be condoning. If you say these things, but you're not, you're helping them, you're educating them, you're giving them another chance to get back in and allow the team to get that on that pathway. So what are some of the things? You can ask them, anticipate possible fentanyl-laced substances. We talked about that, those pressed pills, the marijuana, the meth, we've seen it and all that. Tell them to be alert to that different response, that different taste, that different color. I hear that all the time. I knew it wasn't what I thought it was because it just didn't, it didn't give me the same reaction or the same feeling, and it tasted different. Start with a small amount, test it out, especially if you have a new drug dealer. You don't know that person, or you're getting it from someone that got it from someone else that you don't know. Start with a small amount. Remember tolerance and level that. And we don't know what that illicit fentanyl, the milligrams of it exactly. So remember that NutriBullet story from Dr. Anderson. Avoid using alone. Just like my nurse, she knew to go. She went to a colleague and did it at her house, and had she not done that, she wouldn't still be here. She wouldn't have been given the opportunity. Now that nurse didn't have naloxone. She used she just did resuscitation and obviously called 911 very quickly, and I got there quickly. But she wouldn't have had that opportunity.
There's a number now that you can call. It's a national toll-free number that you can call, so that no one has to use alone. So they may not feel comfortable going to a friend or a family, but they can call, and there are apps, and there's a lot of different technology that if you don't, well, there are ways to do that in the least intrusive way possible. And also there are depending upon the state, in the state of Kentucky, there's a website, and I've actually utilized this. It's from the Kentucky Harm Reduction Group. You go online and you request naloxone, and they'll send you naloxone mailed to your house. You get 2 doses of naloxone, you get fentanyl testing strips and education. So obviously, I think depending upon the state, I know you can do that in Ohio in terms of mail order. There are so many ways to get these materials out there, and I try to tell this to anyone who's persistently using. Tell your friends that maybe you don't want to come into our clinic, or you don't want to go into the emergency department. You don't have to. Here are some resources, and you can make that request. So it's been pretty awesome to see all the different ways technology is being used to save lives.
That's an awesome addition, and maybe we could put that number in there, Katie, on this slide, so folks can have that, and maybe some of the links to those resources you talked about. That's great. Big thing: do not combine with other substances. Deadly benzodiazepines, alcohol, gabapentin. Amazing the number of gabapentin milligrams. I have people tell me they put 800 gabapentin in with all this other stuff. So most overdose deaths do involve more than one substance, and most of them, or many of them, have the benzodiazepine. Benzodiazepines: Valium, Xanax, Ativan, diazepam, lorazepam, and alprazolam are the generic names. Naloxone, get it out there. I carry it with me, have it. One big, just note, post-incarceration. I saw that we had a parole officer, or probation officer, just thank us, and thank you if you're still here, for joining us. But post-incarceration, so remember, folks go in with this tolerance. They're there for 30 days. They don't get their drug of choice. They might occasionally get something, but they're certainly not building, not using daily. And so that tolerance goes back down. They come out, they don't know it. They have no tolerance. They go right back to using what they were using, and they're gone. High risk. Off the top of my head, I want to say it's like 40 times higher in the first 4 weeks.
Think of too, Dr. McClain. I was trying to think of what's that in those first 2 weeks post-release. That's the most dangerous time. And an area of advocacy, if anybody wants to reach out to me, I'm trying to do is Medicaid expansion, getting that on board to those that are coming out of long-term jail or long-term prison, is getting Medicaid enrollment prior to release. My first cousin's been 8 years in a state prison here in Kentucky. He was able, because I think this was a Medicaid waiver, was able to get Medicaid enrolled prior to his release. He had coverage for a year. He was able to have an appointment set up prior to release, and he utilized Vivitrol, and that's very expensive, and it was covered because he was enrolled. So if anybody wants to join in the fight to making sure that those coming out can actually participate in healthcare, even despite their limited resources, reach out. There's strength in numbers, and I need more people on my team. There's also a HRSA grant that was, I think it was a significant amount of money in Eastern Kentucky, and it's called First Day Forward. And what they do is that first day they get these incarcerated folks who are released, and they give them naloxone, they give them basically clothes, anything they need. They set up resources, because what happens is these folks get out, they're given their the same stuff that they were arrested, and so if they're getting out in the fall, or the winter, and it was the spring that they were, they've got shorts and that sort of thing, that's what they get back. So, and then who did they call? They call the people that they know, and generally that gets them right back into that pattern. So, next slide.
this is, we can just look at it real quickly. It's not, I threw it in there if anyone had any questions about the difference in the affinities. It's actually opposite of what it looks like. The buprenorphine has the highest affinity. I know it's the lowest, but they're looking at it a different way. So you go down, that gives you an idea of hydromorphone is next in line, oxymorphone, and then the morphine. Heroin is broken down into morphine and 6-MAM. The metabolite, don't ask me what that is. I bet our chemist probably knows, but and then the fentanyl is right in the middle, and then oxycodone and the hydrocodone, which is Lortab, Vicodin, and then you've got your codeine, which is the least the least binding affinity. Affinity means how hard that substance holds on to that receptor in your body. So buprenorphine likes it pretty well.
It's important to show there because fentanyl having a higher number means it binds less tighter. Again, therefore, it can be displaced. That lower number, the tighter something binds, so the buprenorphine or the Suboxone Zubsolv, it has an extremely low binding number, which means it binds the receptor so tight. Buprenorphine overdoses are actually extremely challenging, and we see that a lot in our pediatric. When some of the buprenorphine products, unfortunately, are left where children can consume them, buprenorphine overdoses are some of the most challenging. They usually require an naloxone drip, and that's just because it does bind so tight. But fentanyl, that higher number, binds it can be displaced by Narcan.
Next slide.
That's just our contact. It's just our contact information. Want to thank everybody for joining us today. I know we did go over. So thank you for those that stayed with us. Feel free to reach out directly to us, reach out to the organizers of the webinar, and we will get the slides out and get the resources out to everyone. And thanks again for joining us.
Thank you all.